My name's Carla. I'm again one of the final years, and we're going to do some OSCE EMQ stuff. I've deliberately made this quite EMQ heavy because I think it's easier for you guys to consolidate what you've learnt today and actually remember some stuff than it is to do your OSCEs, because OSCEs you really need to do one-on-one. Like, I'm going to give you some tips and we'll talk through it anyway, but it's predominantly about the EMQs than it is about the OSCEs. So in your OSCEs, you've got all your main kind of presenting symptoms, and that's what you've got to base your OSCEs off. So don't think about it in conditions. Think about it as you've either got a psychosis, you've got a mood disorder, or you've got kind of a dementia picture. So once you've got that, then you can put your differentials within that. So we'll start off with one of them. So yeah, you got your condition or your presenting complaint sort of thing. Get your differentials out. Screen for anything that comes with that. So like he was just Dan was just talking about, you can have schizophrenia, but you could have schizoaffective. So you could have a mood disorder with that. Screen for those sorts of things. Do a risk assessment. Risk assessment is part of any history, and it doesn't have to be a full one. We'll go through it again, but it needs to be part of everything because everyone is going to have some degree of risk, and you've just got to make sure that there's nothing that's going to happen right here, right now that you need to manage, and then any complications. So for depression, so if you start off, your main differential for depression is a major depressive episode. So that's the history you've got to do. You've got to base it off your DSM. So you go through your depressive history, tick off what they've got. The things that they could have, so you pick up your differentials. You don't need to do all of these in your OSCE. Just pick up, say, 3. You do your 3 screening questions for each of your 3 conditions. So you've ruled out your major differentials. That's all you need to do. Because psych is very talky and it takes quite a bit of time to get through a history. Really make sure you've got 3 questions for each of your differentials to kind of figure out. So you go through those, see if it fits any of those sort of conditions. Ask them, have they had any mania symptoms? Those sorts of things. Anything that could come along with it. So like we just said, the schizoaffective, depression and anxiety often go hand in hand, particularly in young people. So again, you screen for those. Do your risk assessment, and then anything that could result from that. So depression, you could have psychotic depression, you could have melancholic depression, or you could have a suicidal behaviour on top of that, suicidal ideation. Does that make sense? Does anyone have any questions about that? So most of your, I think you probably all know this already, but your OSCEs this year are 8-minute on, 4-minute off. So when you're practicing at home, shorten them up. Only practice 7 or 7.5 minute actives and 3 minutes prep sort of thing, so that when you get in there and you've kind of sorted your mind out and had a bit of a panic, you've got a little bit of time up your sleeve to work it out. Yeah. Anxiety works the same way. So there's a whole lot of kind of subspecialties subgroups under anxiety. So panic disorders, OCD, PTSD, they're all the sort of ones that you need to be screening for. Anxiety, you do need to actually do all of these if they relate to your patient. So if your patient is presenting quite anxious, see if they have a panic disorder, see if they have any of these other ones, because it's very monash to give you more than one thing with anxiety, because anxiety on its own is not a big topic. Again, comorbid depression. Anxiety is very much about functional capacity because it really influences how you manage them. If someone is still able to go to work and they're still able to leave the house, still able to do their normal things, they're unlikely to need to be medicated. They'll go for more of the psychotherapies. Whereas if someone has panic disorder and because of that they can't even leave the house anymore, so they're going hungry, they're not looking after themselves, that's a big issue. Yep. Mania works the same way. So does everyone know the difference between mania 1 and bipolar 1 and bipolar 2? I assume someone's been through it today. Yep. Drug-induced is also a common one, and organic causes are really big as well. That on its own is often quite an extensive history because the mania history is quite big, and you know by definition if they've got mania, they're likely to have had a depressive episode as well, because you can't just get mania, you have to get bipolar. Yeah. You need an extended risk assessment for that as well, because mania is quite heavily involved. Psychosis works the same way. So you could have schizophreniform. So you need to know your timeline of your events, how long they've been having these symptoms, and whether they actually classify as a schizophrenic, or whether with schizophrenia, or whether they have just like the prodrome, and we kind of try and differentiate whether they've got a drug-induced or this is just their first episode and it's not going to recur. I'm going to let you read through all that because I think this is more something you need to work through on your own. Eating disorders is quite good. I don't think it'll be given to you as an OSCE, but your main differentiations is whether they're maintaining their own weight or whether they're not. If they're starting to decline in weight, then they are more likely to fall into the anorexia category. If they're able to keep their own weight, then they'll sit into the bulimia category. Anxiety depression and personality disorders are really common. Personality particularly because it's very much a disease of control. People often find that if they don't have control in their own lives, or they feel really anxious about a lot of things that they can't do anything about, then the eating is what they can control. So this is a lot of what feeds into what's going on in their mind and how we actually manage it. So people with perfectionist traits and people who really need a lot of control or are manifesting like they don't have a lot of control externally, like their parents are splitting up and they can't do anything about it, sort of thing, that's the sort of situations you're looking at. So the complications, again, these are important things that you need to screen for. And because anorexia is the only condition that can really kill you, you need to screen for the biological side of it because they're at high risk of refeeding, but you can also judge severity by how long this has been going on for and what changes they're getting. So if they're getting symptoms of anemia, they're getting postural hypos, they're getting palpitations, it's really common to get ECG abnormalities and period changes. They're really good screening questions to just give you, like, to show that you know what you're talking about, that you know this is a high risk condition, and to kind of look at what's actually going on here. Cognitive changes, I think these are actually quite easy to differentiate once you've looked at them. So Alzheimer's is classically the memory things. So you do your MMSE to kind of track progression. One MMSE on its own is relatively invalid. You kind of need a progressive trend to know what their decline actually is. Lewy body dementia presents very similar to Parkinson's, except Parkinson's you start with the movement disorders and then you kind of get a gradual cognitive change, whereas with Lewy body you almost always get this cognitive change first and then you start getting the Parkinsonian features later on. Yeah? Frontotemporal is classically personality changes, people who get really aggressive unnecessarily, and this is definitely not like them. Like they've been quite a normal functioning person for 50 years and now they're about to retire next year and they're suddenly really angry. That's where it presents. And vascular is very much vascular risk factors, so hypercholesterol, diabetes, obesity, all those sorts of things. Again, Monash really like to throw in depression here. They say that as you retire, that's kind of a big transition in your life and people don't manage it very well. So they always have an EMQ that says, this person's just retired, they're now presenting like this. Are they depressed because they're not managing with this transition very well, or have they actually got something underlying going on? So in your risk assessment, and this is the one that you want to do for every patient that comes in, assess the risk to themselves or assess the risk to others, and anything protective. Protective is the bit that most people miss, but it gives you those bonus marks to say, is this person actually high risk despite these things that are going on? So suicide is an active thing. They're actually planning to do that, and if they have a suicidal ideation, you can look into that further. Deliberate self-harm, which is often a way of feeling something or assessing that they are actually responding to things and whether they have an emotional response, but then also neglect. So someone with schizophrenia is less likely to present with suicidal ideation, but they are quite commonly presenting with neglect. So they're not looking after themselves, they're not eating, they're not showering because they have this functional decline that comes along with their underlying condition. To others, again, the same thing applies, whether they actively want to hurt someone or they've just got dependents who then, if they're neglecting themselves, they're likely to neglect their dependents as well. And then protective features. So there's a lot of things that kind of fall into this. If they have insight, then they kind of have an awareness of what's going on. That's very strongly protective because they are often then more likely to realise in themselves if something is going wrong. If they don't have insight, it makes it a little bit more difficult, but formal things like they go and see their GP every week on a Monday, that's protective because then they know if the GP knows if they don't show up, there's something that's probably not quite right. But also things like family, like I think men are more likely to commit suicide if they're unmarried, if they don't have kids, and if they don't have pets, if they don't have a job, those sorts of things. So they're really good things to just screen for as well. So for some of your other histories, so you need an extended risk assessment. Absconding and compliance with medication or with treatment are ones that you can kind of pick and choose which histories you put them in. And these are the kind of questions you'd ask about and just kind of get an assessment of. For your mania histories, they're that next set, so forensic, sexual, financial, occupational, drug and alcohol and overdose. So in mania, you definitely need to check on all those things because they may quit their job impulsively, they may be spending their money on flights and things that they don't intend on actually taking and having a look. And then driving, again, can fall into a lot of categories. So if you're older or you are manic or anything like that, your driving needs to be assessed. Okay. So suicidal ideation, that can be a history on its own. You need to have a look at it and say, you kind of want to determine at high, medium or low risk. So high risk are often those things that we talked about, the risk factors. So they're male because they're more likely to choose more lethal mechanisms. If they haven't got any protective factors, they are unmarried, they haven't got any kids, they haven't got a job, those sorts of things. And versus the kind of borderline patients who do these really impulsive actions, where they're likely to be, they're attempting suicide, but they're unlikely to be highly lethal mechanisms. So have a look at how they did it, how they got the stuff. So if they were overdosing, did they have to go out and actively buy the medications? Because that implies you've actually had a degree of planning, you're really going out to do this. Or did they have the medications at home already and they just had to pop the blister pack, or they just had to take the bottle? Did they take anything else while they were doing this? Did they have alcohol or anything else on board? And the same applies if someone was going to commit suicide by hanging. Did they have to go out and buy the rope and that sort of stuff, or did they have that sort of stuff in the garage already? Because then it kind of differentiates your degree of planning. Again, if they have a note, if they've resigned for their job, they've made plans, they're in their mind, this is a terminal event. They've decided this is how it's going to be. So you can see what their intention was from this sort of an action. Why today? Was there any precipitants? Did someone break up with them yesterday, or did something particularly happen, or was this something just planned and today just seemed like the day, sort of thing. Intention is important again. So did they just want to get a reaction out of someone? Did they actually think this is going to kill them? Did they say, oh, I'm going to take the tablets and I thought it probably just make me drowsy and I just go to sleep for 12 hours and that would be fantastic because I don't have to see anybody, sort of thing. If they're embarrassed about it now, it's quite protective because then they have a bit of it that shows insight again. And then did they take measures against being found? So did they do it when they knew their partner was at work and they wouldn't be back till 5? They've closed all the curtains and they've locked all the doors so they wouldn't be found. Because that's, again, they have a very terminal foresight in this event. So other histories and exams that you could get, so that's probably more of the histories. The exam we got last year was an assessment of EPSEs, which was it was combined with the history, so you kind of had to identify they had EPSEs and then do an exam of it. We did it as a practice exam last year, so they're the points that we've put up for that. The video one we had was delirium, but you could quite reasonably get a mental state exam based on a video as well. The other histories that I haven't put up would be counselling. So lithium is, the mnemonics are really easy. So lithium is for the side effects and GATE is for the acute symptoms of lithium toxicity. So once you've kind of got those memorised, you just follow your normal IPR-BRAD formula and you can do it. Clozapine and SSRIs, I haven't seen actually done in previous years, I don't think, but they're definitely more than reasonable ones to be getting. That's why I've put queries next to them. This was one of the past questions that we've had EMQs, and so you can see in there. So does everyone know GATE? So GI abnormalities. So this is for lithium toxicity. So GI abnormalities, ataxia, eyes, something to do with cognition, I can't remember, ineffectual cognition or something like that, and T is tremor. So you can see in their question, they've literally just gone by it. So you've got confusion, I'm not really sure blurred speech is a thing, but anyway, ataxia and nausea. So it's very clear that this person's got lithium toxicity. Yeah. Last year, we got this idea of someone from the year above us again. So we just picked out the kind of top topics that we thought could come up in OSCEs. We wrote them down. So we've picked out, I don't know how many, anyway, 8 rotations of 8 topics. So we had 10 people. We each wrote 6 or 7 stations each, and then we went through them as kind of a simulated OSCE thing ourselves, and it worked really, really well. So that was what we did right before, after exams had finished and just before OSCEs, because we had them split up last year. So it works the same. I think it was really valuable to actually write them, and I know everyone says that, but it makes a big difference because you learn kind of the history as you go as well. Cool. Do we have any questions about OSCEs? about general things or about cycloskies? Cool. Okay. So does everyone want to go to socrative.com and then enter this code up the top here? It'll be that same code. So while people are doing that, I have put the slides up on the drive, but I haven't put a heap under EMQs. I've just put some real buzzwordy things. So psychotherapies, I haven't put a lot of questions in the slides about, but it's because they're super basic. Like if you know they've got depression, then you know what to give them. Or if you've got, what do you call it? If you've got borderline personality, then you give them DBT every time. So once you've known those sorts of things, you don't need to have questions on them, I guess. And these are just basic buzzwordy things there you can look at. I don't know how many people we've got. So once you have logged in, yeah, the code's still at the top there. Feel free to answer, and we'll just kind of go through it at our pace. All right, last few, do you want to quickly lock in an answer? All right. Okay, so we've either got schizophrenia or schizophreniform disorder. So what in the question would lead you to one or the other? Or, okay, or delusional disorder. So delusional disorder is a really clear-cut one. They've got these delusions, but they haven't got anything that affects their daily living. So to have a diagnosis of schizophrenia, you've got to have the positive symptoms, the negative symptoms, and the functional decline or cognitive decline that goes with it. You have to have all three. So with delusional disorder, you've only got positive symptoms, you have nothing else, okay? So with him, the mum's noticed a change in him, and he's got these really vague references. So there's something a bit more going on than just delusions, yeah? So to have schizophrenia, he has to have a diagnosis for 6 months. And so they say here that he's had it for maybe 6 weeks and then modes to change for about 3 months. So he hasn't quite met that criteria. So he's still in schizophreniform phase. Does that make sense? Any questions? All right, next one. Leave it 30 more seconds. Or less than that, actually. I'm going to give you 15. Lock something in. Yeah. All right. Okay. So in his mini mental state, he's lost points for articulation, following commands, and copying pentagrams. So classically, Alzheimer's is going to have some memory problems, and in Monash Land, they'll always have memory problems. So he hasn't had any of that. He was able to memorize the 5 objects that you gave him and repeat them 30 seconds later or 5 minutes later or whatever you've asked him to do. So he's had this. So this is just kind of frontal cognitive decline that he's got there. That's what they're trying to tell you with that MMSE. Yeah. And then he's got these fixed false beliefs, and those 2 symptoms don't really fit anything else apart from schizophrenia. Is anyone not convinced by that? No. So if it's not an option, they're very clear. Like if it's close between 2 things and one's not an answer, then they're just trying to say that pick something else sort of thing. But I would say it's not, even if it was an answer, I wouldn't pick frontotemporal here. The picture would more likely be someone who's been quite well for quite a long time, and then all of a sudden in 3 months, they've had a big turn and that's changed. Whereas for a guy who's itinerant and he sounds like he's had this as a chronic thing, I'm not sure that it fits frontotemporal dementia so much. Is anyone else not convinced? Yeah? Good question. I'm not sure is the answer. I don't think that they often do have changes. I think with neurocognitive disorders, they commonly have changes. So vascular dementia often have. Alzheimer's disease often has cerebral atrophy and you get loss of brain matter. I'm not sure about schizophrenia. I don't think that it does. But yeah, sorry, I can't answer that one. Anyone else? Yeah? Not specific to, but it's more leaning towards schizophrenia than it is towards a cognitive disorder, because but more than Alzheimer's, for example, but because it's just small functional changes that you should be able to do at that age. Does that kind of answer your question? No. So if it was a neurocognitive disorder, you are either going to get a global sort of a picture where you're getting little bits here and there, or you're getting significantly memory problems. Whereas this, so it's assessing your visual spatial awareness. So you've got the 2 pentagrams. All they have to do is make sure that one corner of the top pentagram overlaps the second one, regardless of how much. It's just to make sure that that's there. And so that's just the cognitive processing, that they can see what they've got and they're processing and assessing it and able to replicate that. So that could be present in dementia, but it's also could be present in schizophrenia. I think for this, it's more relevant what's not there, what they haven't got changes in. Because in dementia, you'll get cognitive changes as well, but you'll also get memory impairment, for example. Schizotypal is a personality disorder. So they should have full range of cognition. They should just have weird beliefs. Yeah, just an odd person sort of thing. All right. Happy? You guys seem pretty all right with that one. We're good. Next. So just so you can differentiate cannabis withdrawal, you would have to be taking like using significant amounts of cannabis to kind of get a withdrawal. Usually you wouldn't get the anxiety and dry mouth. You'd get more of just a social withdrawal. And if it's after a specific event, usually he's probably been using it at that event. So it's not necessarily likely to be a withdrawal from it. Like the effects last a little while. Yeah. Can I get a show of hands who hasn't done psych yet? Just so I have, oh, okay, cool, yep. This one's probably gonna be more difficult for you. All right. Okay. So it's a little bit hard if you haven't done psych, because I'm not sure anyone would have specifically been through these sort of things today. But the first one is about like an idea that came to them out of nowhere. Like all of a sudden they just started believing this thing, or they just knew this thing. So that's what that one's about. So it's not necessarily they think that they're entitled to be the devil. So it's not necessarily grandiose and that they're controlling all of this sort of stuff. It's just all of a sudden they believe this. Grandiosity is more likely to say that they think they're the king sort of thing, rather than they think they're the devil. Nihilistic would be like it's going to be the end of the world, like not just that he's the devil, but the whole world has got turned to hell and everything's falling apart. Yeah. So this is something Matt just went through. So hopefully we got a little bit. I cannot. That's why I said the first option. No, I'm not going to try. Metonym. So it's using a word in the place of something similar. So it's like getting on a plane and asking about the pilot, but you call them the driver, for example. You're using a word that's similar, but it's not the actual word, and people know it's not the word. Right? Does that make sense? They'd use it in schizophrenia as well. Yeah, yeah. Cool. All right. Good. So flight of ideas, you still have some sort of connection to what you're doing. You're going way off tangent, but there is a connection between all your sentences. Yeah, flight of idea. But whereas loose associations is the actual association between the first sentence and the second sentence and the third sentence, where they just go wherever they want to go. Yeah. What are you going to start him on? Sorry. So previously responded to quetiapine, risperidone, and olanzapine, but he hasn't been taking them. What are you going to discharge him on this time? No. All right, 15 more seconds. Lock in an answer. All right. So this one is really difficult because I disagree with what Matt said. I would say that they would always start you, and particularly in EMQs, they will always go for risperidone over olanzapine because it has a much better side effect profile. And in practice, they really do. Like for first episode psychosis, they always pick risperidone unless there's a good reason not to. So I think when Ian Presnell wrote the questions, which he hasn't done for 2 or 3 years, he used to say olanzapine, but they definitely don't pick that anymore. They definitely say risperidone unless any other reason. Yeah. Olanzapine has a much higher metabolic side effect profile, and it's really not as tolerated as well as risperidone is. Sorry, yeah. So potentially his symptoms weren't well, his positive symptoms weren't well controlled on one. If he was having significant side effects from one, they might have switched him to a better side effect profile, and that might have been why he wasn't actually taking his medication. They may not have realized that he wasn't taking his medication on a previous thing. He might have been started on olanzapine first, and they thought it wasn't working, but really he just wasn't taking it, so they tried something else. Yeah, it's not common to have gone through so many, but it does happen. It's not unreasonable. Switch. So they really try, in psych, they really try to keep to one medication if possible. The only real exception is aripiprazole, that it sometimes doubles up because it manages some of the hormonal side effects a little bit better. So when people get gynecomastia and things like that, then they'll add on aripiprazole because it will counteract that specifically. But generally, they'll try and stick to one antipsychotic at one time. Yes, I would say yes. Yeah, they try one at a time. There's too many side effects that it just really makes it not very tolerable otherwise. Give now, sorry. What drug you should give now to treat it? Sorry. All right, 10 more seconds. Okay. This one's a bit harder. Cool. So he's got an acute dystonia. So he's got an EPSC. So EPSCs are quite common on some of the medications, and unless it's really life-threatening or we think it's a permanent one like tardive dyskinesia, we're not going to necessarily reverse it. We'll just switch the antipsychotic because then they'll go away by themselves. But this is something we worry about because he's having trouble breathing. It sounds almost like he's got respiratory problems or like a laryngeal spasm. So we need to reverse that straight away. The only medication we do that with is benztropine. Yeah. All right. 5 seconds. Well done. So you can either get, I'm sure you've had this explained, so you can either get schizophrenia or you can get depression or you can get the overlap. So she's having psychotic symptoms without the depression. So that in its own is enough to either be schizophrenia or schizoaffective. But because she's having depressive symptoms at other times, that classifies as schizoaffective. Happy? For this, assume that his normal baseline is not playing computer games and staying up late. Reasonable question, but this is copied word for word from a past exam. Okay, so all these questions are past exam questions that the faculty have released, and I've kind of filtered them so that we talk about some relevant stuff. So unfortunately, that's what we get. All right, 5 seconds. Okay. Okay, so I think very reasonable to say normal adolescent because that's what people do. Like, but they're assuming that your normal high schooler is a medical school high schooler. Like, if you guys were doing that, that's what Monash assume. Okay, so they're going to say that that's not a normal reaction, that you're now socially isolating yourself and you're really unhappy and that sort of stuff. Okay. All right, 15 seconds. All right. Yeah, reasonable. So differentiating between mania and hypomania is based on functional capacity. So if she's still going to school and she's still doing her normal activities, but they're slightly disrupted, that's okay because she's still doing these things. So she's still going to class. She's just being a real pain in the backside while she's there. So that would classify that more as hypomania. Is anyone who's still unhappy about that? Yeah. They're essentially the same. It doesn't. Hypomania and mania have the same timeline. It's just to the degree that they're affected by it. Yeah. Okay. Anything else on that one? All right, 5 seconds. Hold on. All right. Hold on. So I would say the difference between these two, I think most of you have got it anyway, that he is still managing to keep up with his normal routine, but he's sad. So he's still doing normal things. Yeah. I'm going to cut the time short a little bit, guys, so we can get through more questions. So I'll see if you can lock them in, and we'll just because I don't want to keep you, like, it's just a long day and I don't want to keep you longer than we need to, that's all. All right, 5 seconds. Cool. All right. So I would say not delusional disorder because these aren't thoughts. He's actually doing these things. He's still making the songs. So he's actually got actions here. So probably not a delusional disorder. Schizoid personality disorder is probably a little bit different. It's again, that really odd just personality. So not, again, it's a personality trait, not necessarily that he's doing this, these actions as well. And schizophreniform, he hasn't necessarily got cognitive decline here, and all the negative symptoms. He's just got these hallucinations. So it sounds like mania because he's quite grandiose. He's high productivity. He's making a lot of songs. He thinks he's so good that he can talk to Barack Obama. Yeah. All right, 15 seconds. All right. So this is a kind of a question of differentiating between whether he needs medical therapy or whether he needs cognitive therapy. So I'd say if he's got a good going depression, he's got poor appetite, and he's got all these kind of constitutional symptoms as well, like he's got the sleep problems and the eating problems and that sort of stuff, that's enough to warrant medical therapy rather than just cognitive therapy. Because of this, so in your list, the only so your antidepressants would be either escitalopram, mirtazapine, or venlafaxine. So you've got an SSRI, mirtazapine, or an SNRI. So hypertension is saying that he's had a history of high blood pressure. You can't use SNRIs because the N part is going to be driving up your blood pressure. The hyponatremia is contraindication for escitalopram because it's a side effect of escitalopram, so you don't want to cause something that he's had previously. So your last one is mirtazapine. The other reason you'd pick mirtazapine is because that's really good for these biological sort of symptoms. So it's a sedating antidepressant, so it's good for sleep changes. What's the other one? Oh, and it's good. It makes you gain weight. So if you've got low appetite, it's a stimulant for that as well. Yeah. Anyone? Sorry? I wouldn't, because he's not an immediate risk. So admission, your question, if you want to admit or not, your question is whether he's an immediate risk or not. If he's not an immediate risk, we try and manage in the community because you're pulling him out of his normal environment. So we might stabilize him in the hospital, but then as soon as he goes back to his normal environment, it's a new upset and a new trigger for a new deterioration, if that makes sense. Yeah. 10 seconds. All right, there we go. Okay. So these are quite hard questions, and it's deliberate so that we can talk them through, because the hardest questions in the exam are always the ones that differentiating between whether you admit or not, whether you give cognitive therapy or medical therapy, and then differentiating between medical therapies. So it's deliberate that way. These are quite difficult. So in her main presenting complaint is actually pain. She's looking for pain relief, but then as a side fact, she's also depressed. So they're telling you she wants an antidepressant that has pain relief as a side effect. Yeah. So that's where your SNRI comes in. Does that make sense to people? Yes. Yes, yeah, they do. I would say that because she's having this disturbed sleep as well, and anhedonia, that will help. I would err towards, venlafaxine. And loss of energy again would be an SNRI benefit. Yeah. So this one again is trying to make you decide whether she wants medical therapy or cognitive therapy. And if she's saying that she's not even going to work because of this, I think. Yeah, she hasn't been able to go to the work for the last fortnight. That's probably enough to warrant medical therapy. So now you're kind of talking, and they've kind of told you as well, she doesn't want it. She wants something that will work quickly, and she doesn't want something that will make her feel too dopey. So it's trying to tell you that we're differentiating between different medical therapies here. So she doesn't want something that's sedating. So we kind of just talked about this. One of them we just talked about is quite sedating, so it helps with sleep. So we don't want that at this point. So you're kind of looking for first line that excludes that one medication. Yep. Okay. Good. Yeah. So escitalopram is an SSRI, so that's usually first line, but they're just kind of reaffirming you're not going to go for something like mirtazapine in that sort of a case. Sorry? All of them will. Yeah, unfortunately, but so will cognitive therapy. So anything that she wants to work quickly is not really going to be quick, if that makes sense. Yeah. No. So in anxiety particularly, they tend to use SSRIs as a standard. Yeah. So again, here you're trying to differentiate between medical or cognitive therapy, and then depend within that subset. Right. 10 seconds. Okay, so again, she's got functional changes. She's scared to leave the house. So she's not confident enough to leave the house. That's a functional change. So that's enough to warrant medication. Is there anyone who's uncomfortable with that? Because it looks quite like when, yeah. She's got panic disorder. So she's getting panic attacks. Yep. So that's quite common of panic attacks where they get them and then they avoid the circumstances that trigger them. So that's where the agoraphobia often comes in. Yeah. Yes. If the agoraphobia is the underlying condition, then yes, 100%. But because the panic disorders are causing the agoraphobia, you want to treat the underlying. So you treat the panic disorders first, and if the agoraphobia doesn't resolve, then we go that way. Okay, so crisis intervention is like if there's an immediate risk to someone. So they are actively suicidal and they are standing on the edge of a building and you've got to, like, if you don't do something literally right now, something bad could happen. It's usually a team. So if in the community, if you call 000 and say this is what's happening, you'll get ambulance, you'll get your ambulance police, and you'll get a specialised ambulance team that have mental health on board. In the hospital, you don't actually often come across this because you don't really get that sort of crisis. Yeah. Okay. All right, 10 seconds. So frontotemporal is a significant personality change. So you're looking for these new aggressions or this new irritability with children where you flick them to the side sort of thing. Like it's not necessarily like this would either fit with kind of an Alzheimer's sort of a dementia picture or a depressive episode. So what they've told you is short-term memory and concentration are impaired. That fits both depression and Alzheimer's. But then they're saying then their other symptoms are poor energy, irritability, and lack of interest in their family. So that's probably more a depressive sort of a thing. Alzheimer's don't lose interest in their family. They just start forgetting who they are, sort of. All right, 10 seconds. Well done. So the Monash buzzwordy thing in this is that the wife was compensating for his decline up until she died. So he was having this decline, but no one noticed because she was fixing everything for him. She was probably cooking for him and doing all the bills and blah, blah, blah. But then she died, and so now it's all come to light. That's very Monashy. Yep. All right, 10 seconds. Yeah. So this is the personality changes that we were talking about. So they said episodes of road rage, which is completely out of character. So really not normal for this guy. Yeah. Yeah, lack of empathy towards his disabled grandson. Yeah, there you go. Cool. Yeah. So frontotemporal, it's not necessarily cognitive decline in frontotemporal. So they can have it, but it's not the pathognomonic sort of thing. So Alzheimer's very much so. Frontotemporal is more the personality predominantly. Yes, but what would cause that? A stroke, yeah. But you'd have to have a background. So in the question, they'd have to give you risk factors for a stroke. They'd have to be trying to tell you this is why you'd think of this over something else. It's very uncommon to get a purely frontal lobe stroke as well. So if you look at the branching of the arteries, when you go to the MCA or ACA, ACA is very middle and MCA is very peripheral. So it's very unlikely you get just a pure stroke. You get a mixed lobe presentation. Yeah. All right. 5 seconds. Look in an answer. Good. So this is a major thing. If she can't recognize that there's even food in front of her, you know you've got major deterioration. And it's whether you say it's, well, which of these it's down to. If they're only talking about mini mental state and she's got this strong pattern, mini mental state is most commonly used in Alzheimer's because that's what it's designed to assess. Yeah. If you're not recognizing the food in front of you, that's unlikely to be depression. That's you have no interest in depression, but you're still going to recognize it. I've designed this to finish at 4, but we've clearly got a lot more questions. I've gone up to about 45, I think. I'm not expecting you to stay. If you want to leave, you're more than welcome to. And if anyone wants to stay, I'm happy to keep going because I think the value is in explaining them. But I'm happy to like download these and send them to you, and you can do them yourself. But they're also part of the past exams the faculty have released, so you've got access to these anyway. Yeah, if there's 5 people, I'm still happy to keep going. Like, it doesn't matter for me. I haven't got anything on, so. Okay, cool. Awesome. All right. 5 seconds. All done. Yeah. So here they're not talking about memory problems or anything like that. It's just that he's kind of slowed a little bit. He's not able to concentrate as much, and it's more about he's disheveled and he's not eating so much. He's just not taking care of himself. Yeah. What do you think you've got? Cool. 5 seconds. Right. Done. So narcissistic is your classic orthopedic surgeon, like real full of themselves, really like the sound of their own voice sort of thing. This isn't her. She's not trying to show off to anybody. She's just really over the top about everything. She's over the top about how she dresses. She's over the top about her reactions to things. That's what you're kind of looking for here. Yeah. This one. All right, 5 seconds. Good. So borderline is classically a secondary effect to complex trauma. So often people with borderline have had really bad experiences in their childhood. So they have this real feeling of emptiness. They really have a big fear of abandonment. It's always about really close, intense relationships that end really quickly, and it's very dramatic. So that's kind of what he's got. He's very impulsive. He's got the mood swings and the arguments with girlfriends, where he's got these really short, intense relationships. Classically in Monash Land, they actually use females because borderline predominantly presents in females, but this is kind of the odd question out. It's as distinct from mania, because mania, you get this hyper-arousal state where he's not sleeping all night, and they're really super productive and they're really goal-oriented, whereas he's just erratic. All right, 5 seconds. Oh my God. I found this question super hard. Well done. Yeah, so this is again trying to differentiate between medication or therapy. Or what medication or what therapy sort of thing. I don't know what I've done here. All right, 5 seconds. Okay. So to get any benefit from therapy, you actually have to engage in it. Like, you can't just sit there and have the person talk, like your therapist talk to you the whole time. You actually have to be able to engage with it. So if he's not going to do it, it's a bit redundant. So you've got to get him, start him on medication, get him to a baseline where he will engage, if that's going to happen, and then you can actually bring in your therapies and get him onto something. Yeah, it's quite a hard problem because it's not uncommon for people to say that, but they'd benefit quite substantially from therapy. Yeah. Say that again. I would agree, cognitive behavioral therapy. Yeah, exactly. I would say that there's nothing there to indicate that he's not functioning well otherwise, that he's just kind of got this anxiety that's underlying. So I think cognitive behavioral therapy would be perfectly reasonable in that case, yeah. Parent therapy is when you've got a really naughty child and the parents need help in how to manage them. So let's do this real quick. So this is the slide that I've kind of made for that. So cognitive behavioral therapy is anxiety, depression. So this is your underlying kind of causes. Yeah. Dialectical behavioral therapy is always borderline. So if you have borderline and you need therapy, it's always DBT without fail. So this is what the other ones are used for. So family-based therapy is used in anorexia nervosa. Family therapy is when you've got issues within the family. So one child is like, you've got a 4-year-old who's got cancer and they've got a little younger brother, and the little younger brother feels left out. And so it's family therapy and how you kind of address that, because you've got a sick child which still needs attention, but you've also got a second child who's feeling really unhappy, yeah? So supportive psychotherapy is just someone who needs a friend. That's really kind of straightforward. Relationship therapy is any sort of a relationship. So it doesn't have to be like boyfriend, girlfriend. It can be like mother, daughter sort of thing. It's just kind of working out the relationship. Inside-oriented psychotherapy is when you've got, so if I've had 6 boyfriends in the past who've all dumped me because they've said I'm too fat, and then I get it with another guy and then I dump him straight away because I think he thinks that I'm too fat, but I don't understand why I've done that. It's kind of trying to look at the underlying cause, and it's because I've had this past history that they're coming through, and it's trying to understand your actions now because of your history. That's what inside-oriented is. Psychoeducation is psychoeducation. You're just educating your patient, and motivational interviewing is trying to convince them. Cool. So here you're differentiating again between medical or therapy-based or psychotherapy sort of thing. So how are there factors here that you'd look at in the question that would indicate you one way or the other, depending on her function, depending on her outlook? All right, 5 seconds. So she's still got symptoms of depression here. Like she's still got full outlook thinking, but she's going to need therapy to kind of manage that sort of stuff. Because it's been going on for 2 weeks as well. Yeah. It is a really fine line for this one, but yeah, cognitive behavioral therapy. So, all right, 10 seconds. All right. So again, this is a really hard one that no one actually explains to you inside. And this is why it's come up. So crisis intervention is something is about to happen and we need to step in before it does. So someone is standing at the edge of a building and they're about to jump and we need to stop that. Admission to hospital is they've already done it, but they're still in that really hyperacute phase and we need to do something. We don't know what to do, so we admit them. Yes. Oh. Okay. Maybe I've got the wrong answer. Leave it with me and I'll get back to you. Sorry. That admission to hospital would make more sense. Yeah. Sorry? Yes. Doesn't she consume 2 drinks of food? She decides to total friend. Okay. I'm not sure, sorry. I would have said admission. Is there any... You have to leave that one with me. Sorry. Yeah, all right. Just leave it there. Okay. All right, 10 seconds. Okay. Okay, so this one is definitely different. So the context for this one is he's in explaining his actions, he said he didn't know what else to do. So he's already kind of past the acute phase where he's now kind of trying to rationalize it. So that's not an acute risk anymore. So they're kind of in that context now saying he's actually taken that kind of next step where he's got someone with him and he's trying to like talk it out because he doesn't know what else to do. So that's where we're looking for like the next step. He's not acutely at risk anymore, so we want to admit him. Okay. The last one was a bit different. I'm not 100% confident on this, but I would say because she's just taken her tablets, she's still at medical risk as well. We still need to manage that, I think would be the differentiating factor here. All right, so the next one. All right, 10 seconds. All right, lock it in. Okay, so application for administration. Administration is for your financial affairs and your housing and that sort of stuff. So that's not going to help him now because he's acutely psychotic, right? He doesn't need an ambulance because he's not at medical risk. He needs to go to hospital probably, but he doesn't necessarily need an ambulance for that. Crisis assessment team is a team that can review you every day sort of thing in the community to make sure everything's going okay. But if he's not taking his medications, that's not going to resolve on its own. He needs to be admitted, and he's not willing to do that by himself. So he's going to get admitted under the Mental Health Act to get these symptoms under control. Does anyone have any questions? No. Application for administration is a financial power of attorney that's sort of a context. Like you're looking for an administrative guardian. Kat would be reluctant to take someone on like that unless they were supposed to be already stable, if that makes sense. So they can do medication supervision. They can go in every day to make sure that you take it. But if he's acutely psychotic and something happens in the community where he thinks his housemates are out to get him and kill him, that's pretty intense, and he could react to that in that time frame. So probably there's a risk involved and you'd admit for that. Yeah? Is anyone else? And treatment team. I don't know what APAT is, so I'm not sure that it might be just by area that they have it. Yeah. Oh, there you go. Okay, it's age. Yep. If you guys want to leave, you're more than welcome. Like, I'll be here, but it's up to you. All right, 10 seconds. Okay. So this is a really difficult one. So he has a strong intention to, but he is not an immediate risk. It's not like I'm saying I'm literally about to leave and kill my brother. So you can't call the police for someone saying I'm going to kill him. Like, do you know what I mean? So you can't admit him under the Mental Health Act because it says that he's stable on olanzapine. He's mad at his brother because his brother's a douche and he wants to kill him for it. That's not a symptom of his mental illness. He just hates his brother right now. So you can't admit him under the Mental Health Act because it's not related to his mental illness. Anger management, definitely reasonable, but your brother's still at risk. You want to manage the brother first, and then you can manage the anger afterwards. So crisis assessment team, same thing. Family therapy, again, long-term sort of solution with the anger management. Yeah. Any questions about that? It's quite a lot in that question. I'll give you a bit of time for this one because there's a lot to it again. All right, 10 seconds. All right. Okay. So it doesn't actually say where you are in this situation. So the conditions of putting someone on an assessment order is that you can actually assess them within 24 hours. You can't be a GP and put them on an assessment order because they're not in a facility that they can be assessed in. So they have to be somewhere they can, or be taken to somewhere where they can actually be assessed. So they really don't tell you where they are. So an assessment order is a really difficult one to kind of, it's probably still on the table, but it's probably not a likely sort of situation here. He's clearly depressed. He's clearly got suicidal thoughts, but he hasn't necessarily got an idea, like an actual formulated plan, because he's asking someone else to do it for him. So he's not an acute risk to himself, but he is definitely suicidal. So there is a risk there. He doesn't need to go to hospital, but it's not like he needs an emergency transport, right? Like crisis intervention sort of situation, because he's not actively trying to do anything to himself. Okay. Does that help at all with, is anyone still unhappy with that? Hang on one sec. Say again. I would say no, because he's still got this ideation, he'd still warrant admission, because we don't know whether that will change within the next 48 hours. If he was severely depressed and this ideation had been ongoing for about 6 weeks sort of thing, probably crisis like CAT team is okay, because that's unlikely to change over time. Whereas this sounds like it's just kind of come up recently. So he's on a downward trajectory. That probably warrants admission because the risk is more imminent. Yeah. All right. All right. 10 seconds. I don't know why I gave you so much time for that. All right. 5 seconds. So reasonable. She's an imminent personal threat. It's like calling a code grey or code black sort of thing. She's an imminent risk to you. Whether she's a patient or not is irrelevant sort of thing. Yep. All right, 10 seconds. Okay. Okay, so again, the administration is literally admin, like life admin, like paying bills, getting your rent sorted, that sort of stuff. Okay, so that one's not it. Admission, so borderline. So she's got borderline. So she's got these. Yeah, she's impulsive. She's unhappy that her therapist left for a week. She's kind of got the suicidal ideation, which is a little bit impulsive, but she doesn't really want to do it. We don't tend to admit for that because it's very contextual, and her therapist is only away for a week. So as soon as her therapist comes back, it sounds like things will get resolved. So we don't really want to admit for that unless we have to. She doesn't really need the Mental Health Act either because she's saying she doesn't really want to do anything bad. She might be willing to be admitted anyway by herself. We don't really need the Mental Health Act unless they're really unwilling and they really need treatment. Yeah, so crisis assessment team's reasonable. Keep them in their own environment and manage them there. Does that kind of explain a little bit about those questions about the CAT team that people were making before? Yeah. That's okay. So CAT team have a couple of roles. So they can be for people who've been recently admitted and they're now discharged, and so they're kind of managing them in that early discharge phase. So they review them however often you say required. Generally, they'll only do once a day, no more than that. They can, but they don't tend to. So they just making sure that once you've made that transition that you're still stable. They can also do, if you're just in the community and you're normally under a mental health team, but you're having a particularly rough phase, then they can come and review you each day to see how you're going, to make sure you're taking your medications, to make sure that you're tracking along, and then they can kind of track you and see if you're getting worse. They can say, well, we actually think you need to be admitted. So they're kind of just an external monitoring service that's a bit more intense than their normal community service. You might not see them that often. It's kind of like it's the kind of the intense, like it's like hospital in the home sort of a thing, if that gives you a little bit of context. No, they don't have to. So that they are a community they're a community service. So you're not admitted, but you could have been. And they're kind of just in like intense community follow-up. Yeah. Yeah, so they wouldn't have. So this question, this one. So this is this the one you're talking about? Oh, okay. So if there's an immediate risk to you and you actually need someone to intervene straight away, they're not going to do that. You tend to review in the next few hours, sort of thing, if you call them. If you've got someone in the community who's generally stable and they've presented to you, their GP, and said, I'm actually I've been on depressive treatment for 6 months, but I'm now acutely suicidal. The GP might say, I'll get CAT to review you. And so the CAT team can come out and assess whether they need admission, or might be able to just follow them up every day for the next week to see if this suicidal ideation subsides or that sort of a thing. So generally it has to be a reasonably well-contained thing. If there's any immediate risk, then you need to escalate straight away. Does that kind of answer that? Does that give you, is there anything you're still not happy with? You okay? Okay, that's good. We did this one. Okay, cool. All right, 5 seconds. Knock 'em in. Good. Easy. Can't fix it in any amount of time. Like she's got to go now. Give her something to fix it. If it's a sort of situation where you've got, if she's flying away in like, if she's going on a holiday in 6 weeks or something, and she's scared of planes, then you can kind of address that with more psychotherapy rather than medication. But this is like an immediate. You need to fix this. So this is looking for side effects. Yeah. Oh, yeah, similar. So she's commenced the second medication, to be clear. Like it's not tramadol causing this. She's commenced the second medication while she's on tramadol. All right, 10 seconds. Good. So this is related to the serotonin, so serotonin syndrome. So once you, this is side effects of medication. So for those of you who haven't done psych, it's probably a bit beyond you. Like this is not something someone's going to lecture you on. You'll pick it up and you'll learn it. Yeah. And citalopram can also be used in pain as well. So that's a little bit. We've got max 10 questions to go. Like there's not many. Can't remember how many. Right. 10 seconds. Again, this is medication, so I'm not so stressed. Cool. Yeah. It's very classic of CLOS. But again, these are things you'll learn. So if you haven't done psych, this is not a now question for you. Clozapine. So this one we vaguely mentioned in kind of context a little while ago. All right, 10 seconds. So lithium plays with your kidneys, yeah, because it's a salt, so it's very similar to sodium, yeah. Reasonable question, actually. I would say lithium is more likely to cause it. I think it's, I would say SSRIs are more, with SIADH and hyponatremia, are probably less likely. I think perfectly reasonable. I think they can both cause it. I think it's just probably more common with lithium. Sorry. This is really hard as well, but again, past question. So it's, once you've figured it, you'll understand it. All right, 10 seconds. Well done. All right. So osteoporosis is really common. They've got a deficiency of their intake. Pellagra and scurvy are both caused by vitamin deficiencies as well. If they're not taking things in, they're not going to have things out. Russell's sign is the scratch marks on the back of your hand from forced vomiting. It's not uncommon. Prolonged QTC goes with bradycardia, goes with hypokalemia. You get electrolyte derangements because you're dehydrated. You get hypotension. You get all those sorts of things. Laguno is the hair that you develop, which is common. It's characteristic. Miscarriage because you don't often get your period when you've got amenorrhea. When you've got anorexia, you're unlikely to actually have a miscarriage because you haven't got your period in the first place. Yeah. All right, 10 seconds. Cool. Okay, so his symptoms sound like mania. They'd perfectly reasonably fit with hypothyroid as well. But the reason I would go against hypothyroid is that pressured speech is not characteristic of hypothyroid. Pressured speech is like you really just need to get it out. You speak fast, but you're not necessarily pressured with thyroid. Lithium can interfere with your thyroid though, so it's one of those ones where they are asking you to try and differentiate. His manic is not necessarily a common side effect of many drugs. Yeah, it's possible, but it's not a common one. I would say lithium level, because if they're saying he insists he's been taking his medications, they're probably trying to tell you this is his word that we're taking for it. Let's verify it. So he's probably low lithium. Huh? Not on lithium. So for bipolar, lithium valproate, There's very, very few medications, like carbamazepine sort of thing. There's a few medications, but in Monash land, essentially everyone gets lithium, unless there's a reason otherwise. Yeah, they wouldn't give you both. Is the trick? There's like it's very deliberate that they've only given you that one. Reasonable, but they're trying to tell you, yeah, reasonable. This is Monash 101. Don't overthink this question because it's really like. So for those who haven't, I probably should have done this before, but for those who haven't done psych, lithium is a mood stabilizer, so they use it in bipolar. Olanzapine's antipsychotic, sertraline's an antidepressant. Temazepam's a benzo, so you know what that is. Venlafaxine antidepressant, valproate mood stabilizer again. Yeah, amitriptyline's antidepressant again. 10 seconds. So you need to. So it's literally just Monash's principles. That's all. You can't start lithium unless you've got rid of the sertraline. So they can be used concurrently if you're in a depressive phase. But if it's the sertraline that's flipped you to mania, you've got to get rid of it first. And otherwise, it's redundant starting them on lithium because they're going to you got two things: one's pushing them up, and one's pulling them down, and you're just in limbo. So you get rid of it first. You don't need to decrease it because they haven't been on it that long. You just get rid of it. And then you would start your mood stabilizer. Yeah. So he hasn't been on it that long. He's probably been on a weaning up dose anyway. Because he hasn't been on it long, you can just take it off. Did I skip a question? Where are we up to? That we did that one. Okay, that's all right. What medication has she taken? Is the question. Like that's like it doesn't really matter what she's taking, but what are you gonna do about it? Mm. So older antidepressants and things like notch your SSRIs and SNRIs, so they're like your TCAs and that sort of stuff. So they're the more dirty ones that don't necessarily act on one specific thing, like serotonin. They act on multiple transmitters. Yeah. All right, 10 seconds. Yeah. So she's got anticholinergic side effects. So she's probably on a TCA because they're very anticholinergic. So always look at the heart first. Yeah. So electrolytes seems to be number 2. reasonable, but electrolytes aren't going to kill you by themselves. The complications of that is what's going to kill you. So you look at the ECG to see if anything's actually happening that you need to fix straight away. I think QTC prolongation is the main one. Yeah, but I'm not confident on that, sorry. All right, 10 seconds. Cool. All right. Can someone explain liver function test to me? Who picked it? Or just an idea of why? Sorry. So I can explain, rationalize it. Sorry. Yep. Oh, okay. Yeah, fair call. Yeah. Is there any other reasoning for it? Anyone else? Yeah. Okay. Yeah. Reasonable. I would say if he's encephalopathic, probably that's not how he'd present. That's probably not encephalopathic symptoms, but I can see, yeah, that's, yeah, reasonable thought process. I would say if they're trying to tell you that he's been injecting, that he's, yeah, got IE and he's probably flicked something off. Yeah. Aggression sexual. It's like a frontotemporal picture. It's like frontotemporal dementia, same sort of thing. He's got a new onset personality change. That's likely to be sorry? I can't remember if this, I think there might be one more question. I can't remember after this. 2 more questions? There you go. All right, 10 seconds. All right, 10 seconds. Man, don't even need to give you this time. Like, what am I even? Pethidin's the green whistle. All right, 10 seconds. Cool. So, neuroleptic malignant syndrome and serotonin syndrome present very similarly, but she's on fluoxetine, so it's telling you she's on an SSRI. So it's differentiating them for you. They're not going to ask you in a question to be able to differentiate them because they're very similar. Yep. Unless they tell you why. So clozapine is actually hypersalivation, not dry mouth. That's not normal for cloz. Yeah. All right. 10 seconds. Tough, I'm doing it. So, yeah. So agranulocytosis is your side effect of cloz. So your big ones. Hmm? Hang on. Maybe I've done it wrong. I think that's what you'd be worried about. Yeah, it still presents with those sort of symptoms. So that's what you'd want to rule out first, I think, is what they're trying to get at. Yeah. Cool. Is that it? Yeah, that's it. Huh? I don't know. It's one of the symptoms, but I can't explain it. Sorry, I don't know.